Hey everybody, welcome back to the ECG channel. My name is Reed, and don't forget that you can download the PDF of today's ECG down, linked in the description below. And don't forget to subscribe to the channel, like these videos if you enjoy the content. So let's jump into it. This is a pretty simple, fun, good, easy ECG, and pretty classic stuff. So let's jump into it. So we've got, first thing we're going to do is we're going to look at the force and the treat of the force from our QRS complexes. And so I like to look maybe at lead 2, whatever rhythm strip that you like. I think it's just helpful. So we have a narrow complex rhythm. It seems to be pretty regular, kind of marching along. You notice that maybe it's a little bit irregular in the sense that this interval seems to be a little shorter. So does this one. It seems to be a little shorter than the rest. But the rest of them seem to kind of tack along at the same rhythm and rate, and so it kind of goes around, throughout the rest of the rhythm. We think of narrow complex rhythms as something arising at least from the AV node and being conducted down that His-Purkinje system because it's a rapid ventricular depolarization, right? That's a narrow complex QRS, and so kind of now we're thinking, well, what could be the cause of this? And so we can get a general idea of what the rhythm is, or excuse me, what the rate is if we maybe start on this solid line and we go 300, 150, 100, 75, maybe 80 beats per minute, right? Somewhere between 75 and 100. We have these more narrow kind of gaps here, but that's only 2 out of the 10 or so beats that we see on this rhythm. Not that concerned, right? This is a pretty decent ballpark rhythm, or rate, excuse me. So that's what we have. And I look for maybe what's my atrial activity, what could explain what's going on. And I think this probably already jumps out at you guys, right? Look at lead 2. Look at what we see. We've got this beautiful atrial kind of background activity going on, right? What does that make you think? That makes you think atrial flutter. But that's just a thought. Let's make sure this is atrial flutter. What is the rate of our flutter waves? Well, we see our flutter waves seem to be, if this one right here lands just after that solid line, this one right here lands right on that solid line, just a hair faster than 300 beats per minute is my atrial rate. We can say my atrial rate here would be maybe, 275 beats per minute. We know atrial flutter is typically maybe 250 to 300 beats per minute, the atrial rate, right? Ventricular rate here, we said was 80 beats per minute. So things are in line with atrial flutter here. What is atrial flutter? It's a regular occurring reentry pathway, typically that occurs within the atrium, obviously, around the tricuspid annulus, which is right around here. And so we get this reentry pathway, and every time it goes, it depolarizes the atria. And the AV node is a bystander, right? Remember, the AV node in A flutter is a bystander. And so that means that the AV node is going to conduct at a certain rate. And so we need to determine how this bystander, I feel like bystanders with a Y. I feel like with this bystander AV node, what is it doing? Well, we need to determine what the response is. What's the ventricular response? How many P waves occur before each QRS or in between each QRS? And so let's march these out, right? We could use maybe lead 2 again. And so I'm going to start from this one. So we have 1, 2, 3, 4. And then we're going to start over again. 1, 2, 3, 4. We're going to start again. 1, 2, 3, 4. So we've got here, in all of these, we've got 4-to-1 conduction, right? This is another 4 atrial flutter waves per 1 QRS, okay? So we have 4-to-1. And then you see, well, maybe what's going on with these more narrow ones, right? You can see that R to R is a little bit more narrow. And so we've got here 1, 2, 3 flutter waves. So that's a 3-to-1. And then the next one we've got is also 1, 2, 3-to-1, right? 3-to-1. You can count them from wherever you want, but at the end of the day, be consistent with how you measure your flutter waves per QRS, right? I'm choosing to start with a flutter wave that's kind of visible right before the QRS complex. But you're probably like, but hey, Reed, why is this flutter wave look crazy? Well, remember, the flutter waves that are occurring right after the QRSs, remember the QRS also have T waves. And if I could draw a T wave without atrial flutter, it would look something like this. So now you have to superimpose flutter waves on top of these T waves, and so that's what you get, is you get these funky looking T/flutter waves, right? And you can use other leads, right? You can use V1 here. You can see nice sharp flutter waves in V1, right? So we've got an atrial flutter with 4-to-1 and 3-to-1 conduction, so we would call this maybe variable conduction. It's not the exact same every time. So now let's continue down our algorithm. Let's take a look at what the QRS is doing. We've got QRS complexes that are narrow. They're upright in lead 1. They're upright in AVF. That tells me that my QRS axis is down to the left. That's good. I've got nice septal R waves that seem to grow maybe a little early there, but that's okay. We transition around V3. We have nice positive R waves, V5, V6. No evidence of hypertrophy of any sort. We're going to look at our QT interval, right? We're going to measure our R to R intervals. We'll find the midway point, and we'll make sure that that T wave ends by that point, which it does. We look for pathological Q waves, which we don't see any. That tells us if there's a previous MI in a certain distribution. And we also look for ST and T wave changes, like T wave inversions or ST elevations or depressions, to look for ischemia or infarction, and I don't see any of those either. And so pretty kind of simple, kind of put this together. What do we have? We've got atrial flutter with variable conduction alternating between 4-to-1 with occasional 3-to-1 conduction with an average rate generally around 80 beats per minute. So I hope this helps you kind of better understand atrial flutter and some of its physiology. If you have any questions about atrial flutter, please feel free to ask. Remember, it's really typically the tricuspid annulus that is involved in the re-entry circuit within the atria, right? And the tricuspid valve, we know, is in between the right atria in the right ventricle. So anything that puts pressure or strain chronically on that right side of the heart might put you at a higher risk of developing atrial flutter. So what could those be? We could say any chronic pulmonary disease, left-sided heart failure that leads to right-sided heart failure, right? So just kind of fun little ideas to think through, right, when you're talking to your patients about maybe what's their risk factors, right? And maybe helps you for your workup of nuanced A flutter. So, alrighty, well, thanks for watching. Feel free to subscribe to the channel if you want to see more of these videos, and we'll see you on the next ECG video. Have a great rest of your day. Take care.